everyone, I hope you're all doing well and welcome to the RadioGraphics podcast. I am Cherie Wang. In this episode, I have Dr. Jonathan Revels with me. Dr. Revels will be going through an often thought tricky and confusing topic, interstitial lung abnormalities at CT, which is a paper in RadioGraphics from Dr. Akinori Hata et al. I'm looking forward to hearing from him regarding this particular topic and this particular paper. I will be discussing health disparity and breast cancer outcomes in Asian women from Drs. Yiming Gao and Samantha Haller. Discussion of health disparities have been brought into the spotlight in radiology over the last few years, and so it should. It is an important topic for us as radiologists to understand, as only through understanding multiple factors which lead to health disparities we can then investigate how we can best improve the health of the different patient demographics that we encounter as radiologists. This publication hits me personally as a woman of Asian descent and as a person within the Asian American community. Before we start, let's see how Asian is defined here. Asian is defined as an individual with East Asian and/or South Asian origin. It is acknowledged that this does not fully encompass the true diverse nature of Asian Americans. The main takeaway here is that this population is heterogeneous, which makes this a very complex and multifactorial issue. Breast cancer disparity in Asian women is not well understood due to relative paucity of data, and there is a perception of a lower cancer incidence and higher survival in this population compared to other racial and ethnic groups in the United States. I wonder if Asian American women themselves also believe in these myths, which can make tackling this issue even more difficult. The incidence of breast cancer among Asian women is increasing in the United States, supported by data from the Centers for Disease Control and Prevention published in 2021. And this data showed 35% of all new cancers among Asian and Pacific Islander women are breast cancer, and the incidence of breast cancer in these populations has increased by 10% in the past decade. However, the problem also lies that Asian women's attendance at mammographic screening is actually relatively poor. In this demographic, race alone does not explain or account for the complex disparities. Place of origin and the length of time lived in the United States also have important clinical implications in the lifetime risk of breast cancer. Asian Americans are the only ethnic group in the United States in whom cancer is the leading cause of death for all genders, as opposed to heart disease for all other ethnic groups. Of all the ethnic groups, Asian Americans are the group in which the risk of breast cancer has increased the fastest in recent years. The lifetime incidence of breast cancer for Asian and Pacific Islander women is approximately 1 in 10 women, compared to 1 in 8 women for non-Hispanic white women. However, within the Asian and Pacific Islander women, there is wide variation between different subgroups. So for example, there is a higher rate of breast cancer among US-born Chinese and Filipino women younger than 55 years old compared to white women in the same age group. As discussed before, there has been an increase in breast cancer incidence in Asian American women compared to other racial and ethnic groups. Among Asian subgroups, the largest increases in breast cancer incidence were observed in Korean women in 1988 to 2006, and Southeastern Asian women in 1988 to 2013. Breast cancer-related death increased markedly for Asian women between 2003 to 2017. This is compared to non-Hispanic white women, where this has actually been declining. The most pronounced increase in mortality rate of the 15-year period was among Filipino, Korean, and Chinese women. This illustrates that the risk of breast cancer within the subgroups under the umbrella term Asian women is not homogeneous, and refutes the idea that there is uniformly low cancer risk among Asian women. Next, we're going to talk about the risk factors which are unique to Asian women in breast cancer risk. So firstly, acculturation. Breast cancer incidence has been increasing among both Asian American women and women in Asian countries in the recent years, in part due to unhealthy habits associated with a Western lifestyle. Foreign-born Asian women appear to be at higher risk for breast cancer compared to US-born Asian women, regardless of the length of stay in the United States. The lifetime risk of breast cancer has also risen among both immigrant and US-born Asian American women. The relative steeper increase in risk among immigrants in recent years may not just be due to rising rates of breast cancer in many Asian countries, which has been attributed to lifestyle factors such as reproductive practices and hormone replacement use, but also a shift in immigrant demographic composition. Current US immigration policy promotes the influx of highly skilled Asian immigrants with a higher socioeconomic status than that of previous immigrants. The association between breast cancer incidence and socioeconomic status is well known, with higher socioeconomic status linked with increased breast cancer risk due to factors related to parity and hormonal contraceptive use. Next, age distribution. Breast cancer incidence peaks at a younger age among Asian women compared to that of other racial and ethnic groups. The incidence of breast cancer among predominantly non-Hispanic white women peaks at age 75 to 79 years old. In comparison, breast cancer incidence appears to peak among Asian women at age 45 to 49 years old, and the highest incidence rates are not always seen in those aged 65 years old or older. These data underscore the need for early screening in this population to allow for timely detection of breast cancer. Data from the National Program of Cancer Registries and the National Cancer Institute's Surveillance, Epidemiology, and End Results Program for years 2004 to 2013 demonstrated a marked increase in incidence of breast cancer among Asian women aged between 20 and 49 years old during this period. This unique age-based distribution cannot be fully explained by lifestyle-related factors and may reflect a component of underlying differences in the biologic factors of disease in Asian women. Next, of course, we have biomarkers and genetics. So studies have shown that Asian and Black women are more likely than women of any other racial and ethnic group to harbor HER2 positive breast cancers, which carries a poorer prognosis. HER2 positive tumors are more often associated with microcalcification than other subtypes of disease. This is an important point as it highlights the potential utility of mammography in this setting for Asian women, regardless of breast density. Genetics in terms of BRCA, BRCA mutations may also be different between Asian women and that of other racial and ethnic groups. A study of more than 30,000 Chinese women with hereditary breast cancer and ovarian cancer demonstrated that there were substantial differences in BRCA mutation variations between Chinese and non-Chinese ethnic groups. Thus, the current population-based BRCA mutation database, which has been derived largely from data on white patients, may not be adequate as a reference standard for the Asian women population. This calls for the need for inclusion of Asian women, and perhaps ethnic-specific databases are needed to optimize testing in individual patients, which can lead to early breast cancer detection and risk prevention for patients and their families. Next, we have breast density. Asian women collectively have higher mammographic density compared to other racial and ethnic groups. Mammographic density was found to be a moderate to strong independent risk factor for breast cancer, with a clear dose response for increased breast density and higher cancer risk. Specifically, among Asian women, this dose response appears to be the strongest in premenopausal women, and breast density is a significantly larger contributor to cancer risk in younger Asian women than in their older counterparts when adjusted for age. It is further conceivable that the preponderance of breast cancers in younger Asian women may be underestimated for those who have not begun or have chosen not to undergo screening, given that Asian women have relatively poor screening attendance. Next, we have body mass index, BMI. Asian women have an average lower body mass index compared with women in other racial and ethnic groups. Greater breast density and higher BMI each have been shown to be independently associated with increased breast cancer risk across racial and ethnic groups. BMI can be problematic in the Asian woman demographic. When BMI thresholds were adjusted to be lower based on Asian population-specific data, this resulted in the shift of 21.3% of premenopausal Asian women and 22.5% of postmenopausal Asian women from having a normal BMI to being overweight. This highlights the limits of generalized diagnostic criteria for a population that is underrepresented in data collection for the creation of these diagnostic criteria. Asian women, despite having a lower BMI, have a higher percentage of body fat compared to other racial and ethnic groups. These lead to an underestimation and characterization of obesity in Asian women, thus impacts on the nuanced risk assessment and preventions that are needed. Next, we're going to talk about screening. So firstly, screening attendance. Asian American women, both US-born and immigrants, have poor screening attendance. However, it is particularly poor among Asian immigrants who also have the most rapid increase in breast cancer incidence and also worst breast cancer survival rates. Even among those who undergo screening, there is longer delay in follow-up after an abnormal screen result and a higher rate of no follow-up compared with other racial and ethnic groups. Next, we have screening access. Access is a limiting factor in breast cancer screening. Asian women who were immigrants who had lived in the US for less than 10 years, those without a regular physician, and those without health insurance had the lowest rates of attendance for breast cancer screening. When financial burdens were removed, this did not improve attendance. There is also a disparity in access to more advanced imaging techniques. The use of digital breast tomosynthesis has increased invasive cancer detection and reduced recall rates. Many Asian women will benefit from this given dense breast tissue pattern and younger age distribution of breast cancer in this demographic. Cultural perspective is important in understanding what are some of the obstacles when trying to tackle health disparities regarding breast cancer in Asian women. Asian women were found to have more cultural barriers than any other racial or ethnic groups. The labeling of Asian persons as model minorities may also further dissuade advocacy among both patients and providers for Asian women. There are several identified cultural barriers for Asian women. Asian patients have a fatalistic view on cancer and will often seek traditional remedies and are less inclined to actively participate in preventative services. Self-perception of low risk and the lack of screening in their own native country are common reasons for Asian women not to undergo screening. Cultural stoicism is real. There's a desire to limit health expenditure. And there is a family-centric rather than patient-centric approach to healthcare. And these patients do not want to burden their children financially or trouble them with transportation issues, and this leads to them not attending screening or health visits in general. However, we should not despair. There are several solutions and things that have shown to work in reducing health disparities, particularly in this demographic. So education and outreach in the patient's native language and care provided by physicians who are of the same cultural background have shown to improve and reduce health disparities. Community-based programs such as mobile mammography units and free transportation can help overcome the challenges related to family and work obligations. Family-centric approach through engaging and including the patient's family in terms of their healthcare can help motivate patients. Patient navigation programs, which are designed to improve breast cancer awareness, dissemination of knowledge regarding screening, and help patients obtain clinic appointments, can be helpful in this demographic in maintaining healthcare access. Lastly, I think it's of great importance is targeted screening advocacy for younger Asian women to increase awareness and screening, given that breast cancer incidence in this population peaks between the ages of 45 to 49 years old. It is of note that the current American Cancer Society and U.S. Preventive Services Task Force guidelines begin screening at age 45 or 50 years old, and this really falls short for Asian women. Before I pass the mic to Dr. Revels, if you are an Asian American woman or know of one that is at the appropriate age for breast cancer screening, please discuss this with them and encourage them to do so.
Interstitial lung abnormalities at CT, subtypes, clinical significance, and associations with lung cancer. An interstitial lung abnormality is defined as the incidental CT finding of non-dependent lung abnormalities such as architectural distortion, traction bronchiectasis, honeycombing, and non-emphysematous cysts affecting more than 5% of the cross-sectional area of at least one of three lung zones. Amongst patients older than 60 years of age, the prevalence of interstitial lung abnormalities has been reported to range between 4 to 9% in those who smoke and 2 to 7% in those who do not smoke. Some of the risk factors for interstitial lung abnormality include increasing age, inhalation exposure such as tobacco, dust, and traffic-related air pollution, as well as genetic factors such as promoter polymorphism and the MUC5B gene. Interestingly, the MUC5B gene is also associated with idiopathic pulmonary fibrosis, potentially suggesting that interstitial lung abnormality and idiopathic pulmonary fibrosis involve a common process. It is important for radiologists to remember that an interstitial lung abnormality is purely a CT finding, and it does not imply the presence or absence of a patient's symptoms. Although interstitial lung abnormality features were previously regarded as insignificant, they should now be included in the CT report because of their potential clinical significance, including progression of disease, association with idiopathic pulmonary fibrosis, as well as increased mortality. Interstitial lung abnormality subcategories are based on the 2020 position paper released by the Fleischner Society, which divided them according to the interstitial lung abnormality distribution and whether features of fibrosis were present. These subcategories include non-subpleural, subpleural non-fibrotic, and subpleural fibrotic. A subpleural interstitial lung abnormality distribution has been shown to have a greater likelihood of disease progression, and presence of fibrosis has been shown to correlate with increased mortality. Rates of interstitial lung abnormality progression on imaging have been reported to be as high as 20% at 2 years and 73% at 5 years. Practically speaking, interstitial lung abnormalities and interstitial lung disease are on the spectrum of fibrotic lung diseases with overlapping boundaries. A study of the radiologic histopathologic correlation of interstitial lung abnormalities previously revealed that 69% of patients with subpleural fibrotic interstitial lung abnormality have histologic evidence of typical or probable usual interstitial pneumonia at biopsy. Among patients with interstitial lung abnormality, criteria to determine which of them may have clinically significant interstitial lung disease include respiratory symptoms or physical examination findings possibly attributable to interstitial lung disease, reduction in pulmonary function or gas exchange possibly attributable to interstitial lung disease, and extensive disease at CT. It is important to remember that the pulmonary parenchymal abnormalities detected amongst patients deemed high risk for developing interstitial lung disease, such as patients with connective tissue disease, are not included in the current definition of interstitial lung abnormality, as these findings of fibrosis in these patients would not be considered incidental. The following plan for the management of interstitial lung abnormalities was proposed by the Fleischner Society. First, those patients with clinically significant interstitial lung abnormality and interstitial lung disease are divided into either high risk or low risk groups. Patients with one or more risk factors for interstitial lung abnormality progression are categorized as high risk. Examples of clinical risk factors for progression of interstitial lung abnormality include history of inhalation exposures, certain medications such as chemotherapies, prior radiation therapy, and previous thoracic surgery. Radiologic risk factors for interstitial lung abnormality progression include an interstitial lung abnormality with basal and subpleural predominance and fibrotic features. The remaining patients are categorized into the low risk group. Next, patients in both risk groups are advised to reduce their interstitial lung abnormality risk factors, such as cigarette smoking. The high risk patients are advised to undergo active monitoring, including pulmonary function testing and CT. Low risk patients are advised to undergo reassessment when they demonstrate symptoms or other evidence of interstitial lung disease progression. With regards to the recommended chest CT protocol utilized for the assessment of interstitial lung abnormality, the examination should be performed with thin section thickness and a high spatial frequency algorithm to allow for a detailed evaluation of interstitial lung abnormalities. An additional prone CT scan is helpful for differentiating dependent atelectasis from an interstitial lung abnormality. Expiratory CT is not necessary. Ultra-low dose CT with use of iterative reconstruction is not recommended because the interstitial findings might be obscured when utilizing this technique. So now that we have covered the general background, features, and treatment information of interstitial lung abnormality, let's review the potential pitfalls and mimics of this entity, and then discuss its association with lung cancer. First up is central lobular nodularity. Although initial descriptions of interstitial lung abnormality included central lobular nodularity, this finding is not included in the current definition. Central lobular nodularity is a typical manifestation of smoking-related respiratory bronchiolitis. The differential diagnosis for central lobular nodules includes bronchiolitis due to infection or aspiration, hypersensitivity pneumonitis, pneumoconiosis, diffuse alveolar hemorrhage, and lipoid pneumonia. Our second group of pitfalls and mimics are dependent abnormalities and suboptimal inspiration. Ground glass abnormalities sometimes occur in the dependent lung, especially when inspiration is suboptimal. The increased attenuation is caused mainly by transient lung atelectasis, which is most commonly seen at the lung bases. Features that can suggest lack of deep inspiration include tortuosity of vessels, anterior bulging of the posterior membranous portion of the intrathoracic trachea, as well as decreased lung volume when comparing the lung volume to previous scans. Assessing for findings of pulmonary fibrosis, reticulation, and ground glass abnormalities beyond the dependent area may suggest interstitial abnormality over transient atelectasis. However, it may still be difficult to differentiate true interstitial lung abnormality from transient atelectasis on supine scans alone, and an additional prone scan may be required to confirm true interstitial lung abnormality. The third pitfall and mimic we will discuss is osteophyte-related lesion. Osteophyte-related lesions are the pulmonary reticular and ground glass abnormalities that are commonly seen adjacent to thoracic spine osteophytes. These lesions are believed to be caused by mechanical irritation from the osteophytes and represent compressive atelectasis or fibrosis. Osteophyte-related lesions rarely progress and are not considered to be a preclinical form of more extensive lung disease. Therefore, localized osteophyte-related opacities are excluded from the definition of interstitial lung abnormality. Our fourth group of pitfalls and mimics are the apical cap and pleural parenchymal fibroelastosis-like lesions. Apical cap refers to a cap-like lesion at the apex of the lung. The prevalence of apical cap increases with age, and this lesion is believed to be caused by chronic ischemia resulting in hyaline pleural plaque formation or fibrosis. It is usually seen as a homogeneous soft tissue attenuation in the lung apex unilaterally or bilaterally. Pleural parenchymal fibroelastosis is a relatively rare condition characterized by pleural and subpleural parenchymal fibrosis and elastosis, mainly in the upper lobes. However, pleural parenchymal fibroelastosis-like lesions are identified on CT in about 31% of patients. On CT, pleuroparenchymal fibroelastosis-like lesions have an upper lobe thickening and volume loss. Apical cap and pleuroparenchymal fibroelastosis-like lesions are not included in the definition of interstitial lung abnormality because they are distinct radiologic entities. Aspiration is our fifth pitfall and mimic of interstitial lung abnormality. Risk factors for aspiration in adults include structural abnormalities of the pharynx and esophagus, neuromuscular disorders, alcoholism, and general anesthesia. Chronic and recurrent aspiration can result in pulmonary findings that mimic interstitial lung abnormality on CT, such as bronchiectasis. Other features of aspiration on CT include tree and bud opacities, as well as central plugging of airways. Our last group of interstitial lung abnormality pitfalls and mimics is infection and post-inflammatory change. Pulmonary infectious diseases can show resolving opacities or persistent scarring at imaging. The findings can be focal or multifocal and often are linear. It is sometimes difficult to distinguish infectious and inflammatory change from interstitial lung abnormality. An example of chronic airway infection that can have features of bronchiectasis, nodules, consolidation, and scarring is non-tuberculous mycobacteria. With regards to fibrotic interstitial lung abnormalities that can be seen on CT after severe COVID-19 related pneumonia, the authors of this article believe that interstitial lung abnormality-like findings may be best described as post-COVID-19 lung abnormalities. Regarding the association between interstitial lung abnormality and lung cancer, they commonly coexist, particularly in patients who smoke. 3 topics regarding the association between interstitial lung abnormality and lung cancer to consider are the risk of lung cancer, prognosis of patients with lung cancer, and complications during lung cancer treatment. Interstitial lung abnormality has been reported as a risk factor for lung cancer. For example, among 25,041 participants in the National Lung Screening Trial, the prevalence of lung cancer was 2.4% amongst the interstitial lung abnormality group, compared to 1.5% in the non-interstitial lung abnormality group. Several studies have shown an association between interstitial lung abnormality and increased lung cancer mortality. Additionally, the presence of interstitial lung abnormality has been shown to be a predictor of poorer disease survival in patients with stage 1 or stage 2 lung cancer. Treatment options for lung cancer include surgery, radiation therapy, cytotoxic chemotherapy, molecularly targeted drugs, and immune checkpoint inhibitors. An increased prevalence of treatment-related complications in patients with interstitial lung abnormality has been reported. Postoperative pulmonary complications after lung cancer surgery are common and include pneumonia and acute respiratory distress syndrome. Interstitial lung abnormality has been reported as an independent risk factor for postoperative pulmonary complications in those patients with stage 1 or stage 2 non-small cell lung cancer. Radiation pneumonitis is a major complication during radiation therapy in patients with lung cancer. It is well known that clinically significant interstitial lung disease is associated with radiation pneumonitis. However, the correlation between interstitial lung abnormality and radiation pneumonitis remains unclear. The prevalence of immune checkpoint inhibitor-related pneumonitis has been reported to be 4.1% amongst lung cancer patients in anti-programmed cell death protein 1 inhibitor trials. In these cases of pneumonitis, radiologists need to take care to try and differentiate between drug-related pneumonitis, a patient's baseline pre-existing interstitial lung disease, and acute exacerbation of the pre-existing interstitial lung disease. Cytotoxic chemotherapy and targeted drug therapy are major treatment options for patients with lung cancer, but it is well known that both of these therapies can cause exacerbation of interstitial lung disease or drug-related pneumonitis. In the 2020 position paper published by the Fleischner Society, it is recommended that great care be taken when using these drugs in patients with interstitial lung abnormalities. The Fleischner Society position paper also recommended that active monitoring for symptoms, physiologic alterations, and imaging depicted progression of drug-related pneumonitis be considered. Let's recap a few key points. Interstitial lung abnormality is defined as the incidental finding of non-dependent abnormalities that affect more than 5% of the cross-sectional area of at least one of 3 lung zones on CT images. Although interstitial lung abnormalities previously regarded as insignificant, they should now be included in CT reports because of their potential clinical significance. Interstitial lung abnormalities often show progression on imaging, with reported progression rates of 20% in 2 years to 73% in 5 years. In addition, increased respiratory symptoms, reduced exercise capability, decreased total lung capacity, impaired gas exchange, and increased mortality are seen in individuals with interstitial lung abnormality. The large percentage of patients with subpleural fibrotic interstitial lung abnormality have histologic evidence of typical or probable usual interstitial pneumonia at biopsy. Several entities are considered to be potential imaging pitfalls of interstitial lung abnormality. Knowledge of these pitfalls is mandatory for distinguishing clinically significant abnormalities from insignificant findings and identifying cases that require further clinical workup. There are 3 main issues regarding the association between interstitial lung abnormality and lung cancer. Those include risk of lung cancer, prognosis of patients with lung cancer, and complications during lung cancer treatment.
I hope you all enjoyed this episode, and as always, take a look at these articles in the print journal or online, where you can also find related resources, such as the invited commentary by Dr. Jessica Lung for the article I discussed. Thank you so much for listening. See you all next time.